My name is Joseph Song. I'm really excited to be here with everybody virtually to talk about something that's near and dear to my heart, which is prostate cancer. I've had multiple family members diagnosed with this, and I think prostate cancer, we'll talk about this a little bit. The treatment and management of it has always been a kind of conundrum for me, at least philosophically, and I'll get into the weeds on why as the talk progresses. A little bit about me. I'm, a partner at Georgia Urology. I actually came from the area I practice in today. So I grew up in Duluth, went to Emory for undergrad, and I left home for all of 10 years where I did my training in St. Louis, Washington University, before coming back to be closer to my family and back in the community that I grew up in. Research and kind of cutting edge technology has always been something I've been fascinated in, and how we use that technology to better take care of patients, to better improve medical outcomes. It's something that is near and dear to my heart, which is why this topic is near and dear to my heart. I work at both Northside Duluth and Northside Gwinnett and Lawrenceville, where I do the majority of my procedures. So what are we talking about today, right? We're talking about prostate cancer and multiple aspects of it, not just the treatment. Number one, we're going to talk about screening for prostate cancer, whether it's, you should be screened, how we do that screening. We're going to talk about the kind of outcomes with prostate cancer, how we treat it, what can you expect if you're diagnosed, if you or a loved one is diagnosed, and how, prostate cancer is different from other cancers, right? By and large, prostate cancer is very, very treatable. This is typically an extremely slow-growing disease, right? I say typically because it doesn't always turn out that way, right? But one statistic that kind of amazed me was that the most aggressive prostate cancers, for instance, have about the same survival and outcomes as some of the least aggressive bladder cancers, right? That gives you a frame of reference for how aggressive prostate cancer is. By and large, it's extremely treatable, especially if it's caught early. Prostate cancer tends to grow slowly, right? The prostate gland is an organ in men that's involved in fertility. So it sits between the bladder and the urethra and the end of the penis, and it's responsible for producing the fluid that carries most ejaculates. Something that a lot of people don't know is that majority of ejaculate volume actually comes from prostate secretions. So, for instance, men who've had a vasectomy, they see very little difference in terms of ejaculate volume because most of that volume is actually produced by the prostate and not by the testicles. As men age, it's normal, not normal, but it's common for the prostate to continue to grow, right? The prostate over time will get larger and larger. And one of the things that can happen is that prostate cells can become cancerous. When that happens, you have a focus of cancer that starts to grow in an uncontrolled way. This is different from just simple enlargement, right? You can have a small prostate and still have prostate cancer. You can have a large prostate and still have prostate cancer. But what defines cancer is really a pathologic diagnosis. And by that, what I mean is we have to have tissue to look at, and that's usually how we diagnose that somebody has prostate cancer, by looking at it under a microscope and saying, gosh, the way that these cells look, the glands that they are forming, they're very abnormal, and that's a classic Gleason score that we give when we diagnose prostate cancer, right? Now, prostate cancer is extremely common, right? So a lot of the questions I get are, gosh, why did I get prostate cancer? Well, there's multiple different factors that go into risks, but most prostate cancers don't have a single identifiable cause, right? Now, some of them will have some genetic component. So for instance, if you have close male relatives that have prostate cancer, then as a man, you will be a bit more likely to develop it later on in life. Prostate cancer certainly has environmental risk factors, right? There's certain career paths that put you at risk. For instance, smoke inhalation as a firefighter increases your risk. Very famous or infamous cause is Agent Orange. If you're exposed to that, there's certain pesticides that can increase your risk for prostate cancer. So there's a host of environmental risk factors. And then in addition to that, there's also lifestyle risk factors, right? So men who are more overweight or obese, People who have more of a high saturated fat, more of a meat-heavy diet, those things can be, shown to increase risk for prostate cancer as high as 30% over the general population. Specifically in terms of genetics, if you have a first-degree relative, right, that significantly increases your risk for prostate cancer, especially if, your close male relative was diagnosed at an early age. And then for men who have a female relative with a history of breast cancer, especially, with the BRCA1 or 2 gene mutations, that also can increase your risk for developing prostate cancer. Furthermore, we also know that African-American men have a greater risk for prostate cancer compared to the rest of the population, with, depending on the study, as high as a 70% greater risk of developing prostate cancer over time. There's also other hereditary syndromes. So prostate cancer can be associated with colon, breast, pancreatic, and multiple other malignancies, especially if there's a kind of a syndromic picture going on. Now, what are some symptoms of men who have prostate cancer, right? Well, the majority of men have no idea that they have it. And this goes back to something alluded to at the beginning of the talk, right? Prostate cancer is not something that affects your quality of life in the beginning, right? So most men, we pick up prostate cancer with screening. This is why PSA checks, annual exams with your family doc or with a urologist. That's why this is so important, because most prostate cancers don't present with the symptoms that, we can sometimes see with it, right? Some of those symptoms can be urinary, right? It can be difficult to hold back urination. You may see a decrease in the flow of urine. Some men may have pain or decrease in the volume of ejaculate, blood in the semen, pressure in the rectum. Sometimes you can even have bony stiffness or pain, right? As you can see, a lot of these lists are things that we oftentimes associate just as a normal course of age. And that's because prostate cancer can overlap its symptoms with multiple other illnesses, right? How often have you woken up and had a bit of a stiff lower back, right? How many men, as they get into their 50s or 60s, will have urgency and frequency, which are symptoms typically of just an enlarged prostate and not necessarily of cancer, right? So it's important that we test for prostate cancer to look for the men who need early diagnosis and can deal with that early. One of the conundrums with prostate cancer, though, is that a lot of men who are diagnosed with prostate cancer have zero symptoms, right? Now, a lot of the illnesses that I treat as a urologist, they tend to be things that affect your quality of life, right? Enlargement of the prostate, where you're having urgency or even incontinence, for instance. Kidney stones, that you can have excruciating pain. Can't plan long trips, overseas or away from medical care because you have this risk of this kidney stone passing, right? People who have, erectile dysfunction issues and can't be, intimate with their partner or spouse. A lot of the conditions I treat are quality of life issues. So, when people ask me, why did you become a urologist? I oftentimes tell them it's because I like improving my patient's quality of life, right? I'm a firm believer that it's not just about how long you live, but it's about how well you live. Well, prostate cancer kind of runs against that grain, right? A lot of men who are diagnosed with it, they have pretty good quality of life, right? They have no symptoms that they have prostate cancer. But the problem with the disease is oftentimes the treatments can affect that quality of life, all right? And we'll get more about the treatments later on. So how do we detect prostate cancer? All right? One way is with a blood test called a prostate-specific antigen, or PSA. It's geared towards prostate cancer in particular, so it's not looking at other diseases. And the second way is with digital rectal exam, in which we feel the prostate. Of these two, I would say the PSA test is the more important one. Digital rectal exam certainly has a role, but as a urologist, I'd be the first to admit that it's a limited test. We're feeling really about a third of the posterior part of the prostate. We're not able to appreciate the entire gland. In addition to these screening tests, there's secondary steps if one of these tests come back abnormal, right? There's other blood or urinary markers that we can consider. There's other ways to image the prostate that we can consider. And finally, if the risk is high, you can consider a prostate biopsy, right? Prostate cancer in general is extremely common, right? depending on the time frame you're looking at, is either the second or the third most prevalent cancer in men. It kind of, vies with lung cancer between second and third place. In 2021, over 200,000 new cases were diagnosed, almost 250,000 men. In 2022, about 33,000 men unfortunately died of prostate cancer. If you look at the epidemiology, about 1 in 8 men will eventually be diagnosed. And if you're African American, it's about 1 in 6 men. Majority of the men who are diagnosed are, over the age of 65. All right. So how do we diagnose prostate cancer? Really, the only way to truly diagnose it is with tissue diagnosis, right? With tissue sampling, and that's a prostate biopsy. Now, there's some ways that we can do prostate biopsy to be more accurate, and that's where prostate MRI plays a role. There's a procedure called a fusion biopsy, right? So for men who have an elevated PSA, who have concern for prostate cancer, especially if those concerns persist after a previous negative biopsy, sometimes if we're able to find a lesion on the MRI, it allows us to repeat a biopsy through a fusion process that increases the yield of that sampling. And then finally, there are various positron emission tests, tomographies, and these are kind of more specific CT scans where there's specific agents that are kind of keyed into prostate cancer. These are usually used for staging, right? So after a man has already been diagnosed with prostate cancer, a PET scan can be then used to determine whether that cancer is outside of the prostate. So after we diagnose prostate cancer, what do we do, right? Well, I tell my patients there's generally about 4 different options, okay? And depending on the type of prostate cancer, some of these options may or may not apply. The first thing you can do is active surveillance, right? This is where you choose to watch and observe the prostate cancer. Now, some of you might be thinking, my goodness, you just were diagnosed with prostate cancer. How could you choose to just observe it, right? This is cancer. Don't you want to treat that? Well, active surveillance really came into the forefront kind of in the mid-2000s. And the story behind it is a bit historic. Back in the 1990s, when the PSA test, that screening test we were talking about earlier, when that was first kind of developed, we started, as urologists, we started diagnosing men left and right with prostate cancer. There were a lot of men that we found cancer in, and a lot of men that underwent treatment. They either had their prostate removed or they had radiation. Some of these focal treatments were not available back then. Well, in the early to mid 2000s, right, urologists looked back and they took stock of where they'd been and where they'd come, right? They said, gosh, we've been treating a lot more prostate cancer because now we're finding it earlier. What did we do to budge the needle, right? Did we benefit these men? Did we improve their quality of life? Did we prolong their survival? And to their surprise and disappointment, a lot of men did not benefit from their treatment. In particular, men with extremely low volume, low risk disease, right? Men who have what we call Gleason 6 prostate cancer. We now call that grade group 1 prostate cancer. But men with low risk prostate cancer did not seem to benefit. They didn't live any longer, right? We didn't decrease the morbidity or mortality from the prostate cancer. And to the contrary, a lot of these men, they developed erectile dysfunction, they developed urinary incontinence, or they had other complications from their radiation and their surgery. And we were actually making their quality of life worse and not better. So for those men, active surveillance started to become a very, a very attractive option, right? The difficulty is, how do you pick the men who actually benefit from active surveillance versus the men who need treatment, right? Well, one way is to say men with lower risk disease should go through active surveillance. But we know that as the cancer grows and changes, it has the potential to turn more aggressive. And there's also the risk that your initial biopsy may have just missed the spot of more aggressive disease, right? So it's always been a bit of a difficult puzzle to solve in terms of knowing which men would really benefit from active surveillance where you don't aggressively treat versus which men should go on to kind of full prostate gland treatment. On the other side of the spectrum, you have men with very aggressive disease, right? Men who have grade group 4, grade group 5 disease, right? And with those, the standard of care remains either surgery or radiation. And that's because these have a very strong proven track record of curing prostate cancer. With surgery, generally it's done robotically, although there are some prostate surgeries that are still done with an open, bigger incision. But typically, these are keyhole incisions where we're taking the prostate out and removing the prostate entirely. We'll go through that in a little bit. The alternative option is radiation, okay? Radiation is where we're giving radioactive energy into the prostate. That energy then goes and tears up the DNA of these cells, and it prevents the cells from replicating. You can deliver that either with radiation seeds, with an external beam, or with proton therapy, but it still amounts to the same thing, still radiation into the prostate cells. And sometimes we can do a combination of one or more of these options to deliver radiation. The fourth option that we'll talk about is focal therapy, right? And this is an umbrella that includes multiple modalities, including what we're going to talk about today, which is the irreversible electroporation, but I'll touch on the rest in a bit, okay? So a bit more about robotic prostatectomy. Typically, 5 small incisions spread out through the abdomen. Through those incisions, we use robotic arms to disconnect the prostate from its surrounding structures, and then we remove the entire gland intact. Typically during this procedure, especially for men with higher risk disease, we'll also sample the lymph nodes. And the goal of this procedure is to take that prostate gland out and minimize the disruption to the surrounding organs and surrounding structures. The very essential ones in this case are the rectum, which sits right behind the prostate, which can be injured during prostatectomy. The nerves that run on the outside of the prostate capsule, kind of famously is described as you're trying to dissect wet tissue paper from the top of this prostate, and you really don't want to tear that tissue paper at all. It's how thin and fragile some of those nerves can be. And then there's the muscle, the sphincter that holds back urine that sits at the apex or the end of the prostate. And that's another structure that we're really trying to preserve during a prostatectomy. Typically, this procedure takes between 2 to 3 hours. Sometimes, if it's a difficult case, it can be more like 3 to 4. And depending on your urologist, it may be home the same day or one night stay in the hospital. Maybe 1 to 2 weeks with a Foley catheter as you're healing. That Foley catheter allows a scaffold for the prostate to kind of the reconnection to heal up around. With refinements in prostate procedure, in the prostatectomy procedure, we've done a better job of preserving urinary control and sexual function. However, even with modern day robotic surgery, there is still a risk for impacting the continence or sexual function. Next, we have radiation, right? With radiation, there's a few different options like I talked about before. With external beam, this is where radiation is beamed from the outside of the body into the prostate gland. It's usually done on a daily basis for several weeks. One of the benefits is that the recovery is pretty quick, right? There's no cuts on the skin. There's no major pain associated with it. And sometimes it can be done in conjunction with the radiation seeds with brachytherapy, where radioactive seeds are implanted into the prostate. A newer technology that you may have heard of is proton beam. This is a way that radiologists can, another way of delivering radiation, sometimes with fewer sessions that you have to do. Now, one of the important considerations of radiation is that radiation really doesn't differentiate between cancer cells and non-cancer cells, right? So radiation will affect the ability of cancer cells to grow and replicate, but it'll do the same thing to non-cancerous tissue. What that means is once you've had radiation, you'll have a much tougher time of healing from future surgeries, right? So as a result, if you've had radiation, it will be extremely difficult, if not impossible, to then go in and remove the prostate at a later date. And any procedures that you have on the prostate or in the pelvis will have a much higher complication rate, will be much more difficult to perform, and will have a higher risk of permanent incontinence or erectile dysfunction. So as a result, I always caution my patients that yes, radiation is extremely effective, right? The side effects are fewer, but it does close off some future avenues in terms of surgical options whereas the converse is not the same, right? So you can always get radiation after surgery, but surgery following radiation can be much more difficult. All right. That brings us to focal therapy. Okay. So focal therapy is pretty new. It historically has not been used to treat the more aggressive prostate cancers. And we've been using focal therapy here in the US really for the last 3 to 4 years. So it doesn't have that 20 or 30 or 40-year track history that surgery or radiation has. There's a few different ways that we can deliver focal therapy, right? One is irreversible electroporation. This is where we use an electrical current to create tiny holes within the cell membrane of these cancer cells, and that results in cell death. A secondary option may be something called HIFU, or high intensity focal ultrasound, right? This is using heat to ablate and burn away prostate cancers. There's also cryoablation, which uses cold, and then there's laser ablation, which is also another heat-based method to laser away and destroy parts of the prostate that contain cancer cells. All right. So how do I typically determine which men need surgery or radiation or focal ablation, or which men can undergo active surveillance? Well, typically we have to make sure that the prostate cancer is still within the prostate gland and not outside of it, right? If you have more aggressive metastatic or distant disease, then some of these conversations may not apply to you. But generally, if it's localized prostate cancer, men with less aggressive disease, grade group 1 disease, or very limited numbers of grade group 2 disease, they may choose no active treatment and go through with surveillance. However, men with more aggressive disease should go on to active treatment instead. Within that, you have these 3 options of surgery, radiation, and focal therapy. Generally, the men with much more aggressive disease, I'll encourage them to go through with surgery or radiation because of the better cure rates. But for men who have more indeterminate, in the middle of the road, favorable or intermediate risk disease, then focal therapy may be a great option, right? And this is where we're going to get into kind of the meat and potatoes of the talk, where we talk about NanoKnife, all right? So NanoKnife, I usually apply for men with the grade group 2 to 3 prostate cancer, right? This is the Gleason 7 prostate cancers. Now, some men with large volumes of grade group 1 or very young men with grade group 1 disease may fit well with focal therapy. And some men who, may not be good surgery or radiation candidates, or some men who are older with grade group 4 disease, they may also be able to apply focal therapy to their cancer. But in general, it's the men with intermediate risk disease, the grade groups 2 to 3. Okay. With focal ablation with NanoKnife, this is an option that doesn't use either heat or cold. It doesn't involve cutting away tissue, and it's something that can be applied multiple times. So it doesn't close any doors. You can go on to have radiation, you go on to have surgery if you need it, but the majority of patients will not need that in the future. The risk for erectile dysfunction and urinary incontinence is so low that it's practically unheard of, right? Occasionally, you may have some temporary issues with ED or urinary incontinence, but it's nowhere in the same ballpark of the same risk, when you have, as compared to radiation or prostatectomy. With focal ablation, we're treating just part of the prostate, okay? And that's an important thing to keep in mind. It's both a benefit of the procedure as well as a downside, right? So if you have multifocal prostate cancer that's in multiple spots, it can make the procedure more difficult, but also leave some prostate cells behind. And as a result, you do have to continue to observe those tissues to make sure it doesn't develop cancer later on. How does electroporation work? How does NanoKnife work? Well, by running an electrical current and varying the polarity of it, right, we're able to kind of pull this cell membrane that has a charge. We're able to pull it one way and then another. And by varying it, we're able to create small holes in the cell. This technology actually was first used to introduce medications into cells. And only when we realized that by kind of amplifying the effect, we can result in destroying a cell, did we start applying it for cancer. Now, importantly, and this is the part that I really want you to take away from this talk, Importantly, with electroporation, you're not damaging the supporting infrastructure around those cells, okay? So this is called the extracellular space, and it's what gives organs their 3D structure. If our human bodies were made from just cells and didn't have this extracellular space, we would just be bags of meat on the floor, right? So the extracellular space is what gives rigidity, what gives structure, what gives guidance to how these cells grow, right? A lot of treatment options, especially ones that involve heat or cold, will destroy the cell, but also destroy the extracellular spaces, the kind of the interstitial space around it, right? Whereas with electroporation, because you're affecting only the membranes of these cells, you're creating these little holes, you're not affecting that infrastructure 3D space, okay? Here I have a little video on how different types of focal ablation work, okay? This first one is giving an example of something that uses heat, right? You're putting in the needle and you're generating either heat or cold. In this case, more heat. That heat burns away the cancer cells. But as you can see, it's also going to dissolve some of that extracellular matrix, some of that supporting structure. And it basically blasts a hole into the 3D structure of the cell. Over time, as the organ heals, it's going to create scar tissue, and the cells are not going to grow back in the same way. With electroporation, we're using a series of needles, right? In this case, it's showing 2, but oftentimes we'll use more, sometimes somewhere between 4 to 5 needles, right? As those needles go in, we're able to bracket the tumor, okay? And then we run that electrical current between these pairs of needles, and that pulsation, right, pulls the membranes of the cell first one way and then another. It creates holes in the cell, and that causes the cell itself to dissolve. Importantly, we're not heating up tissue. We're not freezing tissue, right? So while the cell dies, that supporting infrastructure, that 3D structure remains intact. And you'll see here, this animation kind of showing the coverings to these structures kind of dissolving away, right? However, the blood vessels, the infrastructure of the organ, those things grow back as the cells kind of re-replicate and cover them, but it can grow back without the influence of those cancers. And that's one of the major benefits to NanoKnife. Okay, so kind of a summary of what we just talked about, right? In step 1, before the treatment, you have the cancer cells, they're still intact. Step 2, during the procedure, you're inducing these small electropores within the cell membrane. Step 3, those cells kind of dissolve, because of the holes we're making within that protective membrane layer. And then over the next several days, your body's own immune system comes in and takes away, the debris of these cells. One important aspect that is still under investigation, there's some thought that as your immune system comes in to clear this debris, it may detect the antigens of these cancer cells, right? And it may prime the immune system in some way to help prevent future disease. That part is still investigational, okay? So what can you expect with the kind of standard of care versus with localized prostate cancer treatment, right? As I talked about previously, surgery and radiation, great ways to cure prostate cancer. The success rates are extremely high. However, there's a price to pay, okay? And that includes things like urinary incontinence, erectile dysfunction, effects to the colon and rectum, which are very close to the prostate, effects to the bladder in terms of frequency and urgency. And in terms of radiation, it can sometimes cause blood in the urine, blood in the stool. It can cause radiation burns that we call cystitis to either the bladder, cystitis, or to the rectum, which we call radiation proctitis. And that can result in long-term issues like recurrent blood in the urine or the stool. As you can see, urinary incontinence, right? This is a pretty high range, between 3 to 14%. Part of that is how you define urinary incontinence, right? Do you define it for anybody who has even one drop of leak, one time a year? Or do you define it only as men who are bothered by their level of incontinence? Or do you define it as people who have to use Depends or pads, right? Depending on how you define incontinence, it can have a big range. The other aspect of incontinence is that it can be extremely, negative to quality of life. Depending on the level of incontinence, there's some people who have a strong social stigma, who have to wear lots of pads. It may limit their activities. And it can be a major issue for men as they get older after being treated for prostate cancer, right? With focal ablation, we're not exposing men to as much risk because we're treating only that part of the prostate that's affected. As you can see here in this cartoon, we're targeting just these areas, right? And as a result, the nerves that run on the back and to the sides of the prostate, there's lower risk affecting those nerves. There's different ways that we can apply focal ablation. We can either use it to target just an MRI visible area of disease, or we can use it to treat an entire half or entire region of the prostate. Now, when I first started doing electroporation, I was limiting it to men who had MRI visible disease so that we could watch and observe and made sure that it responded well. I've had such good results with this that I've started increasing the size of what we can electroporate to include men who need hemi or regional ablations. Well, what are the success rates? What can you expect with something like NanoKnife? In general, the success rates are very, very high. Here, this is 94% success, kind of nationwide. I started doing this procedure a little over a year ago. And at 1 year out, I'm currently at 100% success rate, right? Well, we know in medicine, nothing's 100%. You're always going to have those medical treatments that fail no matter how good it is, right? And part of that is I've been doing this procedure for only a little over a year, right? That reflects just how new NanoKnife is. Here at Georgia Urology, last year we were the first group in the Southeast to introduce this technology. This is an area of urology, I think, that is rapidly growing. I'm very proud to be able to offer it, okay? At 3 years, there's very little difference between NanoKnife and radiation. Part of that is going to be patient selection, right? We've been very careful to select the correct patients, men with very aggressive cancers. I still wouldn't recommend NanoKnife, but with men with the right type of prostate cancer, it's virtually indistinguishable in terms of outcomes. And one other thing that I stress highly is that NanoKnife doesn't close any doors, right? And that's an important aspect to know. Whether it's getting surgery for enlarged prostate later on, whether it's getting surgery for prostate cancer later on, or whether it's getting radiation for recurrent cancer, all of those avenues remain open after NanoKnife. And as a result, it can be a great option for men who are in that intermediate space, who aren't sure what their best option is, or who just really prize being able to lower the risk of erectile dysfunction or stress incontinence. Lastly, and this is the aspect of NanoKnife that I'm very interested in pursuing, is I mentioned earlier that men who've had radiation may not be good candidates for future surgeries. Well, NanoKnife is kind of sparing the tissue enough that there may be applications for salvage NanoKnife in men who've had radiation and had their cancers come back. And this is one avenue that we're still, investigating. So key takeaways about prostate cancer, things to know from tonight, right? Number one, prostate cancer, I don't want patients waiting until they have, symptoms of prostate cancer, because oftentimes by then the cancer is more advanced, more difficult to treat. So get screened, especially if you have a family history, especially if you have environmental risk factors, right? It's one of the most common cancers in men. Most people know at least one person who's been affected by prostate cancer, but it can be a difficult topic to discuss, right? So I always encourage patients, especially when they're first diagnosed, to talk to your friends and family, right? You'd be amazed how many people have gone through, prostate cancer, and are excited to share their experiences and to help, guide others through it, right? And then lastly, know that there's multiple options, right? Depending on, the comfort of your urologist, they may have a set of options that, they use all the time. But I always encourage my patients to get second opinions, to broaden their views about prostate cancer and know everything that's applicable, right? So if you or a loved one, has prostate cancer, you want to come and discuss it with me, we have set aside slots for patients to come in and not have to, wait the 4 or 6 weeks that you typically would to get in with a specialist. So you'll see on the screen here a QR code. If you follow that link, or if you go to georgiaurology.com, you can make an appointment with me. Just make sure to put webinar as your visit reason so that you're taking advantage of some of those set aside patient slots. And that way you don't have to wait as long to be able to come in and discuss things. All right, so I'll leave this up a bit. And with that, we'll take questions. Okay, so I'll go through some of this list here. So one question that I received was, what is the recovery time for Nano? How long after IRE surgery should one be able to drive? Okay, so good question. NanoKnife, because it's less invasive, the downtime is significantly decreased. In general, I advise patients to not drive within 24 hours of anesthesia. Beyond that, most patients right after NanoKnife will have a Foley catheter in place as they're healing, okay? That Foley catheter is to make sure that any swelling in the prostate doesn't pinch off the urethra and lead to urinary retention. I'm only now seeing some of the sound issues. Sorry about that. It doesn't lead to retention. So while you have a Foley catheter in, you should also avoid driving during that time. So typically about 3 to 4 days is the recovery in terms of not being able to drive. Right after the NanoKnife, you'll also have some frequency and urgency. Depending on the kind of volume of treated prostate, sometimes that frequency and urgency can last as long as 4 to 6 weeks, where you're having to run to the bathroom a bit more often because of the irritation to the prostates. All right. Next question, what Gleason score qualifies for NanoKnife? It's not just the Gleason score, it's partly also the volume of prostate cancer, but typically I would say the Gleason 7s and below, right? With Gleason 8, Gleason 9, Gleason 10 prostate cancer, your risk is going to be a bit higher, and you may not be as good of an option for NanoKnife. Next, what do I mean by GI rectal issues? All right, so I think that was the part of the talk where I was talking about radiation. And that's just because radiation doesn't differentiate between prostate cancer cells, normal prostate cells, or the bladder or the rectum, right? So as a result, radiation can cause things like radiation proctitis. It can cause diarrhea. It can cause other, GI symptoms, and sometimes that can be long-term. Next question, is this an abdominal procedure or is it rectal? And then second part of that same question, does NanoKnife provide any BPH relief? Oh, great question. Okay. So the NanoKnife is not transabdominal or transrectal, right? We do use a ultrasound to help visualize the prostate so we can make sure we're treating the correct areas. However, the needles actually get put in through the perineum, which is the bicycle seat area, the skin between the rectum and the scrotum. Usually, you'll see a little bit of bruising, some needle marks there, typically just 5 needle marks, but no cuts in the skin. Next, does NanoKnife provide any BPH relief? Anecdotally, I've seen many men come in with an improvement in their BPH symptoms. And in terms of measuring prostate size after NanoKnife, I've seen a significant decrease in prostate size as those treated areas of the prostate kind of involute. So as a result, anecdotally, again, I do see some BPH relief. We wouldn't be applying NanoKnife to treat BPH, but you may experience some benefit in terms of BPH relief. Do any other MDs in my practice perform this procedure? In particular, Dr. Chen. There are multiple other physicians in my group who do this procedure. Whether your specific doctor offers it or not, I would ask them. I know Dr. Chen has sent me a few patients to consider this procedure for him. Next question, how often do you need to check your PSA after NanoKnife? Very good question. The first year afterwards, I'm a bit more aggressive. I'll check at 3 and then eventually space out to 6 months. And then in addition to that, if you had MRI positive disease, I'll also repeat a MRI, okay? Looking at the next question, it was about prostate PSA being elevated. In terms of whether you need a biopsy, I think it depends on PSA kinetics. In general, I advise patients one rise in PSA isn't necessarily meaningful. I care more about the trend than one test result, right? How do we follow prostate cancer after the procedure? So absolutely, we use PSA, we use MRI, and we use biopsy to kind of follow that along. Next question, what about steam or water treatment to shrink the prostate? Can this be done at the same time? So I think this is likely referring to some of the BPH treatments that we offer. In particular, steam is Resume or water pressure is aquablation. Those are really applied to men with just a benign prostatic hypertrophy or BPH and wouldn't be applied at the same time as prostate cancer treatment. Next question, what about insurance coverage? This is something that we're struggling with, right? NanoKnife is such a new procedure that we actually have a whole team dedicated towards appeals and pushing it through in terms of insurance coverage. This is something that I think will improve over time as more and more insurance companies come on board. But whether your insurance specifically covers this procedure or not yet is kind of a case-by-case basis. Let's see, next question. We've got some great questions tonight, all right. How long does this procedure take? It takes generally about an hour of anesthesia time. When you include kind of waking up and time spent at the hospital, of course, it's going to be longer than that. But in terms of the procedure time under anesthesia is usually about an hour. Do I have any before and after photos? I do not actually, so there are before and after MRIs and ultrasounds. I don't happen to have any with me today. That's a good idea. I think for future talks, we may incorporate something like that. All right, next question. Let's see, how long is one to sleep? We kind of addressed that. As effective as biopsy. Okay, very good. So is a PET scan or MRI as effective as a biopsy in terms of detecting prostate cancer, right? So the diagnosis of prostate cancer is still primarily made from a biopsy. That's the gold standard to determine whether cancer is present. A PET scan or MRI may guide where we put those biopsy needles, but still at the end of the day, taking the tissue out of the body, examining it microscopically, that's still how we actually diagnose prostate cancer. All right. Individual case-by-case details, is something that we should address, kind of individually. So I think if you have specific questions about, your case, I'd highly recommend making an appointment so we can talk about it. I think those things, really should be assessed kind of a case by case and in detail and in person. Let's see. All right, going through some of these questions. I think a lot of the ones have been answered. Let me continue to look here. Oh, if someone has had radiation, does it affect ability to treat kidney stones with ESWAL or ureteroscopy later on? Generally, no, it's not an issue. Is Nano covered by Medicare? It depends, so it depends on the type of Medicare. We've had a lot of success lately with getting NanoKnife through the Medicare coverage. But, again, it's a case-by-case basis. Does PSA go down after nano procedure? Absolutely. So I've seen a big drop in my men who've had prostate cancer treated with NanoKnife. I generally see it go down to about 1/3 to a quarter of what it was previously. But depending on the case, sometimes you get a bigger or smaller drop. Should one expect pain and discomfort after IRE? You shouldn't have severe pain, but you may have some spasms, some pressure, some discomfort in the pelvis afterwards. But compared to, say, a radical prostatectomy, it should be significantly less pain. And I think that takes us to the end of the questions. All right. Anybody else have any questions that they want to put into the chat? All right. Excellent. Well, there's not any more questions. I appreciate everybody for their time. Thank everybody so much for, for coming out tonight. If you have any specific questions about, your medical diagnosis or how to proceed, I'd love to sit down with you and kind of review things with you, and we'll go over things together. All right. Good night. Take care. It was good chatting with everybody. Have a good evening.